So I hope you all are enjoying your second day of IPSSV. What a great way it's been to start the day with introductions, workshops, posters, and so much more. If you missed any of it, you can find the video in the platform, or the morning introduction will also be on the homepage of the IPSSV website. I'm Pavan Zaveri, a pediatric emergency medicine physician at Children's National Hospital in Washington, D.C., and a member of the meeting organizing committee. And I have the great pleasure of introducing our next keynote speaker, Dr. Victoria Brazel. Dr. Victoria Brazel is a professor of emergency medicine and director of simulation at Gold Coast Health and at Bond University Medical Program in Queensland, Australia. As a fellow ER physician, we often share the same goals and challenges of creating teamwork and applying simulation to that space. Dr. Brazel has told quite the story of fostering collaboration through her many publications on trauma teams, maternity teams, and so many more places using simulation, particularly helping all of us translate the work of simulation from mannequin to bedside. Victoria is an enthusiast in the social media and FOAMed world, and she is co-producer of Simulcast, as well as hosts the Harvard Macy Institute podcast. Follow Victoria at Socratic EM, or look her up at drvictoriabrazel.com. Please help us welcome Dr. Victoria Brazel as she speaks about healthcare simulation for shaping relationships and culture in high-performing teams.
Wow, thank you so much, Pavan. That's a very generous introduction, and morning, afternoon, whatever time it is where you are. Lovely to be here with you, and already having a bit of a look at your social media feeds from the conference. Looks like you've had some great presentations and some very thoughtful contributions. I hope today we can focus a little bit of a deep dive on this concept of relationships and culture in teams, and in particular, maybe some potential for shaping those with simulation, which probably many of us have an inkling of, but I hope today we're going to do a little bit of a deep dive. So I will just share some slides here now. What I'll say as we get started with the presentation is I'm extremely enthusiastic about stopping at a couple of instances so we can talk in depth and so I can get your thoughts. So please, and with Tenzing's help, we're going to look at the chat. So if you've got an idea, if you've got a question, if you vehemently disagree, I'm hoping you might put that in the chat as we move through some of the thoughts that I've got here. So let's think about high-performing teams. And if we have a look at a picture like this, which is from one of our trauma simulations, you get the idea about teams being a little bit complicated. And we can imagine that there's all sorts of things going on here. And as simulationists, we might be familiar with thinking about how we can improve that. If we do a little bit of a deep dive, and I think this is perhaps one of the things we've been thinking about with simulation, is how do we actually use simulation to understand what is going on, not just try and make it better, because often we don't necessarily identify the issues that we do need to work on before we start trying to fix them. But if we have a look at this team, you know, we've got an anesthetic registrar here, and we can imagine that he's got a particular focus. We've got our surgical registrar over here. She's pretty new, let's imagine, and her boss said it'd be good for her to go to the sim, but she's also pretty new to trauma. We've got two airway nurses here, one of whom might be supervising the other one, and so they've got some dynamics at play. We've got an emergency consultant who on this picture looks a little bit unhappy, but maybe that's just because she's trying to get the surgical registrar to do something, isn't sure where the boss is. So we know all these dynamics exist. And I guess as we think about simulation shaping team performance, one of the things to think about is that we can explore what's going on here and hopefully shape it. So a little bit more about me. As Pavan said, I'm an emergency physician, and so this is the Gold Coast University Hospital where I do a lot of my simulation work. And I have sort of moved from and work in parallel as a clinician, as an educator, as a simulation specialist. And since 2013, I've really been working on this translational simulation, thinking the lovely translation from mannequin to bedside that Pavan talked about. And I guess I've transitioned maybe to a role of being a team coach. And what I've reflected on over the last 7 or 8 years is that to do better simulation, I had to learn more about teams and teamwork, but also I had to learn specifically more about the teams I was working with. So a little bit more on that later. But I did want to very early on get to some take-home points here. Because when we look at this sort of team, and this is, again, another one from our resource room, as many people in the audience do, we do a lot of in situ simulation, particularly for those teams who are trying to work on optimizing the environment and the systems and have a complex composition in their team that is going to be very hard to put together any other way. As I said, really trying to understand how this team works. And here's just a few thoughts that I've got, even before we go too far into the talk. And one is that unlike sometimes in our positioning as clinicians, it's easy to understand when you're looking at the team as a whole that, in fact, lots of people are right. And the way to resolve conflicts in different perspectives and different priorities is not to try and convince one group that the other group is right, but rather to just recognize that these competing realities exist. Second is that although we're very attracted to these standard operating procedures, and of course they are useful, they are not enough. And if only we could be like the Formula One teams, that'd be great. But of course, there are some very important differences in the complexity in healthcare. And so trying to both understand that and shape it is pretty important. And one of the things that we've been working on recently is that, in fact, understanding the team is really important for our simulation design. And the reason for that is that what teams bring into sim is a huge impact on what they take out of it. And some of the work that we've been doing is on psychological safety. But I think that we've come to understand that whether the team is got high levels of psychological safety to begin with, whether that team knows why they're there, whether that team already has some cohesive approach to trying to get better, will actually influence how they approach their simulation and what they get out of it. And I'm not sure that at least I have had enough appreciation of that in the time that I've been doing team training. So I think that what that means for me as we sort of think about a team like this is we've really got to design and or revise our sim strategies to accommodate those things. That some of those strategies can actually be really simple. And we've been working on some much simpler ways of optimizing team performance and optimizing the outcomes that we get from simulation. And perhaps most importantly, because I've found that getting to know these teams is the key to success, conceptualize simulation as a strategy and not just an event. So how did we get here? I guess we know that, good behaviors in teams foster good outcomes. That seems pretty easy. And many of us spend time in simulation training to try and get these good team behaviors happening. We put names to things. We're much more sophisticated about this than we ever used to be. I think, though, what we know, though, is that underneath those team behaviors, a lot of underpinning feelings, thoughts, ideas that we might shape as, or that we might describe as culture, we might describe as values and beliefs. And again, anyone that's spent any time doing simulation work, either as a participant or as a facilitator, knows that, networking and good collaboration is one of the outcomes. And I think maybe if we were to consider, the concepts of how we incorporate that and how we actually translate that into better, maybe one of the things that we've done is to take a bit of a research-based theoretical deep dive into what good relationships mean. And I'll just mention a couple of theoretical frameworks that we've used before I go into a couple of examples. So the first is the concept of relational coordination that we've used as a way of exploring, in particular, our trauma teams, but some others as well. And for those who are not familiar, this is a theory that's described by Jody Hoffer et al. From Brandeis University in the US. And it's not a surprise, but it puts some names to things. It says that teams that work well together have shared goals, shared knowledge, and in particular, shared knowledge of each other's roles, and mutual respect, together with communication, as you can see, that's good. The second theoretical framework that we've often taken into the work that we've done is psychological safety, and that's nothing new either for the people on this audience. But to actually look at ways that we can measure that, both in quantitative and qualitative ways, and then look at ways that we can use those sorts of data to help deliberately identify ways that we can foster psychological safety beyond simply doing around the room and saying it's a safe space here in simulation. And I guess I want to just give a shout out here. One of my research fellows at the moment, Dr. Eve Purdy, who's an emergency physician and anthropologist, has been very influential here in really describing the cultural compression role of SIM and the signals that we send through our design choices, whether that's how we represent our patients, whether that's how we represent our colleagues, who's in the simulation, the kind of things we choose to focus on, the kind of unconscious biases that we might perpetuate through our simulation design, delivery, and debriefing. So I do think that we've got a great tradition in simulation of learning from other fields, but I think we can look even broader to some others that might be helping us to understand this incredibly important culture shaping impact of the choices that we make. So let's go on and have a little bit of a think about trauma. So this is the first example where I think we started to think a little bit more about relationships and culture. And again, we know if we're involved in this kind of environment that relationships do matter. And if we happen to know, as an emergency physician, the surgeon who comes down to the major trauma, things are going to go well. If we happen to know the anesthetic team, the medical imaging team, if we happen to know our own team well, we know their names, that these things are going to go much better than if we're all just random practitioners hoping that we all understand what each other are doing. And if we kind of look at the complexity of who's in the room here, it's much more than often is represented in simulation training sessions. I think we have a good way of getting doctors and nurses together to do training. But once we start expanding out to interdepartmental things, and once we start expanding out to the people who we know are really important, like our porterage staff, the social workers, and others who end up being critical elements of our team, we start to see just how complex this is. And I certainly know that 10 years ago, if I was approaching this, I would have been thinking very much along the Formula One, that if we can just get all these people to undertake these certain behaviors and do their closed loop communication, this is all going to go well. But we took a little bit more of a deep dive than the Formula One approach and said, well, why don't we actually identify these groups who are involved in trauma care? And why don't we give them some surveys, do some focus groups with them, and specifically ask them how they feel about their colleagues. And we use this relational coordination framework. And so we said, okay, to the surgeons in there, when you interact with the trauma service, do you feel like you've got shared goals? Do you feel like you have a shared understanding of each other's roles? What is the level of mutual respect? After a lot of data collection, we came up with some really important things. And one of the things we also asked is, what is the role of simulation? And at this point, we'd been doing trauma simulations for about 5 years. And we were gratified and a little surprised with what we found. Of course, there are occasional references to people learning more about head injuries. But when we started to foster some of these conversations in relation to relational coordination, yes, we heard some of these good behaviors were important. But we heard many more things about the relationship and culture shaping activity that's going on here. And we learned also about what the debrief did, and certainly the debrief was a good way to discuss the relationships at hand, the issues at hand of whatever simulation we did. But I think perhaps even more importantly, this exercise also signaled some really important things about our commitment to getting better, role modeling conversations, often between quite senior staff, about how we resolve those multiple competing realities in the room. And what we also developed from this group as we were doing our research is some ways that we could look at those relationships better. And in the relational coordination theory, we go looking for certainly relational interventions, but also structural and process ones. How do we find ways to communicate better with the CT radiographers when we're coming to CT, trying to get there safe and fast? How do we foster orientation for our new surgical fellows so that they understand our norms about working together in the resus room, not just at a practical level, but also at a conceptual level? And we wrote a little bit about this, which gave us, I suppose, a little bit of what you might call evidence about something that I guess we know happens, but to understand how it happens and then to understand how we can use that. And I guess for me personally, what I started doing was actually using words in relation to mutual trust, shared goals, and shared knowledge. And the lexicon of relational coordination became a way that we could actually explicitly focus on that as we were doing simulation, but more importantly, how we were doing it in the real world. So I'm just going to pause there for a minute, and I'm going to stop sharing and just see if there are any comments, questions, thoughts. Help out Tenzing, otherwise she's going to have to think of something clever to say so far. But yeah, I'll just pause here and see if there is something people would like to write in the chat for us so that we can pick up on some threads and or any questions or comments that you've got even early on, Tenzing.
Yeah, I don't see anything in chat yet, but there were a couple of things that I jotted down that you said that I thought sounded interesting. And one was that getting to know the teams is really the key to success. And so I can see where you're going with that. I guess from a sim program perspective, like who is it that you're saying gets to know the teams? Is it the sim program? Do you like bring in people from the department, or if you could expand on that, that'd be great.
Yeah, sure. So I guess I think everyone's process will be different, but what I discovered was I'd go to a team and run a sim, and that'd be good. You know, people would enjoy it. People tend to. You'd often get some, even if you're running translational, some very practical things. Oh, we should shift that monitor there. We should do that. What I discovered was the teams I'd been working with for 6 months, not only did it feel better going there, but they were just really firing. They would come in ready to get more out of the sim because they knew both the process, they understood what we were trying to achieve, and they had got better at getting better. And so it also helped me because I started to understand what were their pressure points, what was important to them at both a clinical practice level, at a relational level, and other things. So I think the answer to your question is it is both within the teams because they start understanding that the relationships and the familiarity can be fostered not just through sims, but in other ways that support that. But also because if I'm going to be their team coach, and I think that's the way for us, those of us who do team-based training and simulation, I think we should be thinking of ourselves as team coaches. And I think everyone knows that coaches do better when they get to know their players. And so I think that's the analogy that I would take to it. Whereas I think sometimes, at least for me, I would have previously thought, I've got the sort of wisdom about teamwork. Let me share it with you and tell you a few things about it. Whereas I think that misses an important step of diagnosing our teams and really thinking, where are they at? And I noticed one of the comments in the chat, you know, sometimes they are dysfunctional, these teams. And, you know, you can say whatever you mean about the word dysfunctional. Sometimes that means that they just don't think the way I do. But it's true. Some people haven't got good relationships, and that does impact on their patient care. And I'll tell you without fear or favor, I'm not a all things intervention. I don't think we can come in and fix people necessarily, but I think we can take people wherever they are, and we have to take our time. And I guess that's my point about simulation being a strategy, not an event, because you certainly can't come in and just say, here you go, here's some wisdom, you guys will be fine now, I've taught you how to do closed loop communication. I think it's a much more in-depth understanding, and some of that involves spending time with these teams outside of simulation so that we can make sure we get the most with it.
Yeah, I was going to say there's one question that kind of dovetails into that about whether you should do team training that's not, or team building exercises that's not sim related.
Yeah, absolutely. And I will probably come back to that, so I might hold a little bit. But the short answer is perfect. Yes, we've started doing much more of that than we ever used to in short, sharp doses. And I think that's really been more helpful than I had appreciated previously. I think many of us are attached to our all singing high intensity simulations, and these do have a big impact, but they are very resource and time intensive. Whereas I think we can get a lot out of playing a short role game at handover in 5 or 6 minutes, or doing a huddle and a mental rehearsal at the beginning of a shift in ED, and probably get lots out of that as well, because it's a consistent habit. I did just want to pick up on one thing here, because it was a question specifically about this example and our relational coordination approach. Yes, we do share it. So one of the things that the Relational Coordination Collaborative is, they actually come up with a number, which isn't meant to be a correct reflection, for instance, of how well the anaesthetists and the surgeons get on, but it is meant to stimulate some conversation. And I was amazed at how much it did. So yes, we would come back with the results of our surveys, presented in focus groups to each group, and sort of say, what do you think of this? Why do do you think it is? And we then got a whole lot of very rich information about how people thought about their relationships and why. And in many of these rooms, I was an outsider, which was a little bit, I guess, unusual. Many of us as clinicians, we spend our time within our silos. And so it was very interesting to get a really deep dive into what people were thinking. All right, well, I might just keep going with a few slides here as we continue to have a bit of a think about some of these concepts, because I did want to talk about some other contexts that might be useful. And this one is an interesting one for me. We've been working with our maternity teams over the last 12 months or so. And this is a photograph of a postpartum hemorrhage simulation. And once again, I think this has got some similarities, but also some important differences to what we did with trauma. On the face of it, it looks like another high acuity team. Bleeding also seems to be a big problem in both of these. So there's some clinical similarities, but there's also some important differences in terms of the roles that people take. And in fact, one of the things that was really different about this team was their conceptualization of having clear roles was very different. So 10 years ago, I would have just been very keen again to think, oh, we better get this team focused on their behaviors. And here I've got a list of great crisis resource management behaviors that we can do with you. Whereas we went through the same process with them of really trying to understand who was involved in these, took our relational coordination theory again and said, well, these are potentially the players in this postpartum hemorrhage, and how do they feel about each other? How do they feel about their work? And what do they think good looks like? And what does not so good look like? And again, we got lots of data, and I'm probably not doing it justice here today. And so we did these surveys, as we said, some narrative questions presented back as focus groups. And we looked at the role of simulation again, and then devised interventions. And so here's, once again, some of the things that we got out of our groups. And again, it's not exactly surprising what they came up with. But again, you can see the importance of terms like respect, of things like trust. And out of interest, these are the interventions we came up with. The concept of role allocation was a little bit less normal for this group, which was sort of surprising to me. And then I realized that, in fact, the obstetric doctors and the midwives had a lot of cross coverage of skill sets that didn't lend itself to clarity of role allocation. Whereas when we were in our trauma room, there were very clear things that different professional groups could do, and so they stuck to their roles. Whereas here there was much more cross coverage, and yet that paradoxically was getting in the way of good work in their birth suite, because it meant that everyone was trying to do everything. We also worked on some clinical debriefing, because that was one of the outcomes, that people wanted to do more reflection on real practice. They totally changed their morning handover. The anaesthetic registrars told us they felt like doorstops at the handover. No one knew their names. They didn't know what was going on. And this was really confronting to the midwifery and obstetric doctors. And so they changed the room. They now say, hello, my name is, at the beginning of handover. They've put a couch in there. It's a much nicer space, and has made a huge difference, apparently, now that we've come back 12 months later, to how their work goes. There was, speaking of groups that maybe don't have great relationships, we had a particular group who have a relatively independent practice model, the midwifery group practice midwives, and their relationships with the doctors were terrible. And, you know, they said it, the doctors said it, it was no secret. But I guess we sort of looked a little bit deeper than just terrible and started to understand how we might look at that. And clearly just running more simulations wasn't going to be the answer when it came to thinking about postpartum hemorrhage. Of course, we worked on things like our behavioral interventions, as we would, and simulation was a modality, but wasn't the end goal of what we were doing with these teams. So I'll just make a mention about this so-called difficult group. And we quickly realized that just running a 10-minute sim with some groups who had some deep-seated distrust of each other wasn't going to be the answer. So instead, we used this TV show called One Born Every Minute, and we took about 12 minutes of video of this couple who were trying to have a VBAC, vaginal birth after cesarean. And we just played the video, and then we paused, having all the groups in the room, and discussed what was going on there. So none of them had to feel like they were under the pump and performing, but they were able to have some conversations about what was going on. And we got some astounding feedback from this, what was actually only about an hour and a half to 2 hour exercise. I think we possibly have, and we have repeated this exercise, and I think we've done more for their interprofessional understanding than I could ever do by just putting people in a room with a woman having a PPH. So I think it made me think there were lots more diverse ways we could focus on our team development and the team relationships. So I'm just going to, again, sort of stop sharing there for a minute because it's just another example, I suppose. Tenzing, if you can, are there any other thoughts or comments that people are coming up with?
There are a lot of comments and thoughts. Goodness. So sim and silo is not always cohesive. When we do sims all together, what is your best approach when sim culture is different?
Sim culture is different, or you mean?
It says sim culture. I wonder if people have different perspectives of sim or how to use it. Or
yeah, you're quite right. I mean, I guess this probably goes to something I will mention shortly, which is what approach do you take as an institution? And it's quite true. We were pretty lucky because we didn't have much when we started at the Gold Coast, so it meant we all worked together pretty much from the get-go. But I did come from an institution where practice and simulation practice was more siloed, and people in ED did it a certain way and people in anesthesia did it a certain way. And I think that's much harder. I've had the good fortune maybe to have a strong hand on this is the way we do it across the whole institution, and a fairly big institution at that. So we've probably helped that. But one thing I have learned, and this is again with Eve's help, is there are certain nodes within each group, and I use that term carefully, of people who are incredibly influential on the rest of the group. Once again, this isn't something that is foreign to us. We know this. But to put a name to it and say, this is the node, or these are the couple of nodes in this group who can help us transition those cultures between different ways of approaching simulation, I think is one way of doing that. I don't have a simple answer to your problem, though, but I do think the work you do beforehand is what really makes the difference if the sim is going to be productive or not.
Yeah, that was
any others in here?
The buy-in from different teams and departments. So I think that you kind of addressed that. Would you want to expand a little bit more on cultural compression, that term?
Yeah, sure. Happy to do that. I think one of the things that became apparent to us when we did this, and the first study we did this looked at actually a student simulation where we were doing it was a large ward-based ED sim where there's multiple patients there at once and multiple students. And what we found was that the values of emergency medicine were actually transmitted very powerfully through the way that we had designed that sim. There were multiple things going on. There was a time pressure, but also the supervisors in this sim were behaving completely to type, including some not very good things. And when they played the role of inpatient registrars, they weren't very nice. And we went, wow, this is, sending a very powerful messages that, it's going to be us and them out there. But I don't want to say it was all toxic. Most of it was actually very good. Most of it was, we're a team. We work together with the nurses. Patients are at the center of what we need to do. We need to think carefully about their experience. So there's plenty of positive cultural compression that was being transmitted, but there was more than a couple of little things where we realized, wow, we actually have got some deep-seated values that we are transmitting across. But even in some of the choices we make about how we choose to represent our patients, and in particular one we've been working on recently is some equity, diversity and inclusion. Because what we know is that if all your patients are 50 to 70-year-old white patients, that will send a message about who we think is important in our patient groups. And so thinking about how to just have some greater diversity, both in our patients that we're representing, but also in how we might represent our staff and the kind of conversations we might have. So I think the short answer is there's a lot of values that are transmitted while we're doing our simulations. Oh, and thank you, Tenzing, for putting up that recent blog post on that. Yeah,
I'll get the link in there in just a second.
Yeah, fantastic. All right, well, in the meantime, I will just go back to a couple more examples that I've got here, because one of the things, as I've started to allude to here through looking at relationships and culture, is that sim can do harm. And I think we understand sim can do harm at some levels in that, well, if we put some fake medications into the clinical area, that can cause physical harm. I think we also understand about sometimes people have a bad psychological experience in simulation, and we might do harm in that regard. But I want to talk about the harm we can do in perpetuating stereotypes or perpetuating dynamics between and within teams. And this was something I hadn't thought much about until I worked with a group who really, interestingly, wanted to spend more time together and work together. So our pediatric emergency group and our pediatric surgical group had decided that they wanted to do some sims together because they really wanted to build their relationship. And this wasn't by any means a toxic relationship. It was pretty good, but they wanted to cement it more. And they had one enthusiast in particular who had done quite a lot of sims and who set about designing some pretty complex sims that were involved both pediatric surgery, emergency department, and peds critical care. And I was at these sims, and I suppose maybe because I wasn't running them, that I observed some dynamics that were interestingly being perpetuated. And that was that pediatric surgeons were never in the sim. They were only ever in the debrief room giving advice to everybody about what they should have done. And I'm probably exaggerating here, but you'll go with me with the examples. Sometimes the sims, because maybe not all the interactions between pediatric surgeons and emergency physicians were well represented by a 15-minute simulation. So they ended up being a little bit contrived as well. And I think also in the debrief, the way that these conversations were going were perhaps perpetuating an idea that wasn't a level playing field. There was airtime that wasn't equally shared between doctors and nurses and others in the team. And so we can see that subtly this program perhaps was perpetuating the very things that it was trying to address, because we hadn't specifically designed this simulation, specifically been intentional about the conversations we would have and the messages we would send. So to cut a long story short, and this was quite a painful reflection for a couple of us, because we thought, this isn't terrible, but it's also not right. And so we had quite a few conversations about how this could be more right. And it has involved both some better choices about our simulation design, and in a couple of cases, not doing a sim in the resus room, actually having some large group hypothetical case-based discussions that still talk through a patient journey, but then require people to put some equal skin in the game, as it were, and so that everybody is sharing their vulnerability, not just some groups who are then being critiqued by other groups. So I put this example in because I think this would never have occurred to me until a few years ago, when I started thinking about what was really happening, not just in our debrief rooms, but before and after. So let's come back. So I guess some of this sort of wraps up into the work that we have been doing in psychological safety with our emergency department teams. And this is more recent work, looking at how do you really get teams working together. And again, Eve has led this research, and there'll be more coming on this soon, I hope. But she's taken, again, a little bit more of a deep dive. I mean, we all think we know psychological safety from SIM. We go to great pains to try and set it up in our pre-brief. This is all well-placed work. But I think we have surprisingly discovered some lapses in our psychological safety, both in our emergency department and in our simulations, which we were not aware of. In the emergency department in particular, the consultants thought we had a very flat hierarchy and everyone was very approachable, but we had some, and a lot of others agreed, but we also had some pretty sobering findings that not everybody perceived that same level of flat hierarchy. So as a result of this deep dive, we've kind of looked at some of the elements of psychological safety, and there is an entire research on this, which I can provide people with details if they want to. But we've discovered that there is a huge mediator of psychological safety, and that is team familiarity. Again, this makes logical sense, but what does that really mean? It means the extent to which people actually know each other, and in particular, how much they know their leaders, both clinically and in simulation. And so we have unashamedly looked at lots more simple, short ways to foster that team familiarity so that we can get more psychological safety in the clinical world, but also so that that team brings more psychological safety into our sim, which means we can already start to think about taking more risks, pushing more boundaries, having braver conversations, as it were, about our practice. So some of these look familiar to many people in the room, no doubt, but we have sort of cemented a bit more of a commitment to having those interprofessional huddles at the beginning of shifts, often doing a 5-minute mental rehearsal. We have some little cards that we use that just describe a short vignette. Imagine this patient's coming in having a seizure and it hasn't stopped for 5 minutes. What would we all do? We just talk through it, but also trying to reconceptualize our after action review exercises as not just quality improvement, but as a deliberate strategy for fostering team familiarity. A rather amusing example is Eve herself somehow got to be responsible for doing the mandatory training in our department. And instead of just sending people emails and said, you've got to do your online mandatory training, she actually put us in groups. So I'm in a group with a registrar and 2 junior doctors. And when we all do our mandatory training, the intern goes into a draw for a $200 prize. So of course we feel very responsible to our team to actually get our mandatory training done. So you can see that there's actually lots of opportunities for us once we start realizing that we have to be building that team familiarity. So what does this look like at the institution level for us? A couple of years ago, we've had a simulation service for a while, but a couple of years ago, I decided that probably we needed to reconceptualize that a little bit about not just what we did, but what we were trying to achieve. So we've actually had our board and executive endorse a high performance teamwork strategy at the institution, which is simulation informed and enabled, but also in partnership with groups like the Relational Coordination Unit, with groups like the Quality and Safety Unit, and really thought a little bit more about how do we build high-performing teams and who else is involved in the hospital. So yes, sim is part of it, but it's not the only part. And one of the roles simulation plays is exploring, diagnosing, and identifying, and not just norming to better behaviours. So I do find myself in lots of less familiar rooms like this one, really trying to understand what's happening, because I know this team is probably already pretty good, but I know that they want to get better. So in answer to the final question, how can this team's performance be shaped by simulation? I think, as I said right at the beginning, be really aware. I'll go back to my title slide here. I think we've got to be really aware that this team will benefit if we recognise there's multiple realities in the room, if we recognise that the standard operating procedures aren't enough, and if we recognise that relationships and culture really do underpin their performance. So for us as simulation deliverers, we need to shape our strategy so that we can build on those things. I think we need to make really careful design and delivery choices. And I think we need to build on and use those adjunctive strategies for teamwork. So I will stop there, Tenzing, and see if there's some other thoughts or comments.
I think one thing that we all struggle with is that a lot of times our teams are more ad hoc. We have residents rotating through from outside places all the time. And so they're never static teams. And so even if you train one team together, they're never going to come together again. So any thoughts on how you would be able to extend like psychological safety or get them to connect when they change all the time like that?
Yeah, and I think that's a reality, isn't it? And I think this is one of the reasons why we do need to build individual skills in team working as well as the team building itself. But I think we also maybe can have more influence at a department underpinning relationships and cultural level that mean even if people come together in a more ad hoc team, they've got some shared understanding of what's important. And I think if you've got that, that really helps people's behaviours because they're prepared to ask each other, I don't know. They're prepared to help each other. I've got a better idea. And I know that's a roundabout way of saying that, but I think the teams that I work with a lot, I see some of that disappear because more work is done at that underpinning level about what is beneath the observed behaviours that we do. The short answer, though, is we can't do everything. I'm also pretty quick to say that, our high performance teamwork strategy still only touches small percentage of the hospital. And I think trying to find ways to leverage that through not just having the sim people do the work here, but recognizing that we can set a little tone for those everyday small moments that then the teams can do for themselves. And when I see those maternity teams play their flat Maggie game at handover, where they have a little role allocation game that goes for 5 minutes, I think, well, they're actually working on the team being better in the PPH later in the day, but it doesn't need to be a very high specified sim.
Yeah, there was a comment about doing debriefing sessions, maybe just around a table with the teams or happy hour or something.
Yeah, and I think people are starting to reconceptualize these as learning conversations, and I think that's a good way of doing that. I think the ones we have with sim have some important similarities and some important differences with the ones that we have, say, in clinical event debriefing, but I think we don't learn enough from our practice. And I include not just the clinical decision making that we do, but also the team predicaments or successes that we find ourselves in are under reflected upon. So I think if we can give people frameworks and words, whether that's relational coordination, whether that's some words relating to psychological safety, I think that really helps teams, because they can start to give names to concepts that they sort of know are there, but they don't know how to talk about them with each other. Things like, were we doing the right balance of implicit versus explicit communication? Things like, what was our trade-off between speed and safety? And I think some of these frameworks, if we use them deliberately in sim, people can start to use those words and that language when they're reflecting on their real cases.
Wow, there's a lot of comments here. Can you talk about maybe how you would measure relational coordination? Is there a way to do that?
Yeah, sure. So the Relational Coordination Collaborative, if you look up their website, they actually have a validated instrument that you can do, and it gives you a quantitative measure. My ethnographer anthropologist isn't a big fan of numbers, but it's funny how the doctors and nurses are. So people do actually rate their relationships and communication with the other groups in this survey. And it's actually had quite a lot of psychometric testing. So you can measure it, but I think it's important when you then present those findings to the groups that you don't say this is right, but rather this is a really good place to start a conversation about why. So it truly is a mixed methods approach. So the short answer is yes, you can measure relational coordination, but I don't think we want to just think about it as a quantitative measure, but I think you can also measure it in terms of the qualitative data you get and the kind of analysis you can do on that as well. It's a bit more of a deep dive. You do need to be committed, but I think then the concepts are probably much more wide-ranging.
Maybe time for a workshop our next conference or something.
Yeah, exactly. I did. I see a couple of comments here about civility. Totally agree with that. It's funny how important that is. And I did see the comment here about play and humor. I think that probably goes with a lot of things, doesn't it? I think you have to be careful. One person's humor can be another person's offense. We realize that. But I think certainly where I come from, that is a cultural norm, is using humor as a way of teams getting better at working together. It's a good sign if a team is throwing humor at each other, that they're actually doing a good job of their relationships.
Great. Well, I think that we are just about at time. Yep. So thank you so much for this thoughtful and thought-provoking talk. There are tons of questions still. So if you all want to stay in the Zoom room, we have a 30-minute chat that's ongoing that we'll try and get to all these questions. Otherwise, there's a networking that's open as well. So you can just exit and go to that. And there's a little video that we will be playing. Yeah, go ahead, Pavan.
We'll give people a couple minutes to reset where they want to be and move around. And then I think we can go back and get some of those questions and some of the thoughts from the folks here.
I know, I'm trying to keep up with all the questions.
You did tell me you had a group that was very enthusiastic, Tenzing, and they haven't let you down.
Yeah, it's so nice to see all these comments. I'm glad that you can keep up with the chat too, because I'm not good at multitasking at things like that. So I appreciate that.
I'm not sure that any of us are good at multitasking. I think the evidence would say none of us are very good at it.
It's all about parallel or serial processing quickly.
That's it, isn't it? Task switching.
Exactly.
Yeah. And kidding ourselves that we're still doing a good job.
Okay, let's see. Anne has a question. Could you talk more about the high performance teamwork strategy and who are the key institutional stakeholders and how you got them invested?
Yeah, sure. So we're getting going with that?
Yeah, sure.
Yeah.
Or if
sure.
you want to do a different question, feel free.
No, this is perfect. Yeah, let's do that. Yeah, and I think I just sort of wind back a little bit. As I said, I think we found ourselves working with a number of groups, and I was looking for a way of formalizing that was probably what happened rather than the top down, the other way around. We had done this research work. We actually have a unit called our Relational Coordination unit, which did some work long before we were involved with other groups around the hospital using this as their guiding framework, but without the enabler of simulation. They would come in and do some of that measurement work and would then work with the teams to make recommendations, but wouldn't have a sort of arm to effect that, as it were. If the teams didn't do it, it just didn't happen, the interventions. So I think it was really good that we got together because we could both inform their data collection, but also be a bit of an effector, as it were, for when they had some interventions. Some of them could involve simulation, obviously not all of them, but some did. So we found ourselves working with this group. We also found ourselves working with quality and safety, and a little bit of, almost frustration that I felt like we weren't getting good information from them about what we should be working on and with SIM, and we weren't giving them the kind of great information we felt like we were finding in the clinical world as we went and did a lot of translational and in situ simulation. And then there were a range of people in the hospital doing work on what we called professionalism projects. So these were things like speaking up for safety, a lot of the messages that I think we were trying to send and work on, and we didn't want it to be disconnected from the other programs that were happening in the hospital, particularly in relation to some of those communication and professionalism activities. So to some extent, this was a way for us to form an umbrella group who would come together 5 or 6 times a year and go, well, what teamwork priorities do we feel like we have at the institution? And then we would do a little bit of a deep dive. So we don't try and fix every team every day, but what we do is each year we identify 2 or 3 groups that we're going to spend some time on, and we kind of work with them on what they want to spend time doing. And as I said, with maternity, it ended up being postpartum hemorrhage. With some other groups that we've got, and we're going to do another project with them on induction of labour, other non-contentious type topics. And we do both this diagnostic phase as well as an ongoing what do we want to work on and improve phase, as well as a designing interventions phase, which includes but isn't restricted to SIM, as I said. And we thought that was pretty important to get that endorsed by the board and endorsed by the executive. And that was just such an easy sell because, when you go and you say, so we've got 6,000 clinical staff in this hospital and they work in teams and we don't have a teamwork strategy. It's a bit of a no-brainer. People go, oh yeah, of course we should have a teamwork strategy. So the other thing, and I guess my position, this was both helpful, but it's a bit by design, not by accident. I've got a conjoint academic position with Bond University. So one of our partners in this high-performance teamwork strategy is a research centre. We've set up our Bond Translational Simulation Collaborative, and that then gives us this sort of academic arm where we can add this research framework to the work that we're actually doing to make the teams better. So does that answer the question? Can I provide anything else?
I was hoping you'd also talk along that same lines, like then how do you measure your improvement or the outcome, like and how do you give that ROI to your leadership?
Yeah. So this is interesting because most people would like to see the number be better. And in some cases, we can make numbers better, getting to CT faster, getting more people thrombolyzed in half an hour, getting patients to theatre for the red blanket. So there's some projects where we can say, here, point to this time-based target or point to this compliance target with a particular strategy. I've really tried to shape our customers to think differently about their outcomes. And so we do quite deliberately gather a lot of qualitative data as ways of illustrating the depth of impact that this is having on people. And these aren't, I mean, in the talk, I gave a few quotes, but I guess we've got a bit more of a rigorous way of analysing those, that we really can provide people with information that is meaningful in terms of what impact has been had, not just from SIM, but also from others. I've also tried to coach people to think that it's not a done and measure the outcome, but rather it really is a sort of partnership and a strategy that people are doing. The other thing I'd say is, because we increasingly think about these as our clinical departments, as our partners, that if they're not happy, this doesn't happen anyway. So I think they end up being the greatest promoters of the idea, and they end up being the people who provide the resources, i.e. their staff time and commitment to actually doing something like this. So we don't have any extra money for our high performance teamwork strategy, because actually it's all embedded within departments and they have to decide if they've got the commitment or not. So I know that doesn't completely answer your question. We had 7 out of 10 before, and now we've got 9 out of 10, but I think I've tried to encourage people to think about it differently in terms of outcomes.
Yeah, we see that a lot too when we do some team training, and just everyone just feels better after, and so they just keep coming back.
Yeah, exactly. So engagement is a useful thing.
Yeah. Does anyone want to unmute and ask any questions? If not, I have more.
I was the one who asked about the relation. My name's Anisha. I teach emergency at Lurie Children's in Chicago. I'm interested in team reflexivity in the ER and acute care teams. That's what I'm studying this year. I guess, how would you describe the relationship between TR and relational coordination and the interplay between those two concepts? I'm kind of having a hard time wrapping my brain around it.
Yeah, and look, I think when you use any theoretical framework, reconciling one with the other is tricky. We've actually done a little bit of that, where we coded our most recent data for both relational coordination and psychological safety, and you see some overlaps. I think having a theory is good. I don't think you have to have I think you can have a plurality of the good. You can have many good theories and then just decide what you're going to go with. I don't think you have to say this is the only way of thinking about it. I think at an institution, if you choose one, just as I said before, that can help give people language and a kind of nexus point around which they do that. In my head, and you almost certainly by now, if you're doing work on it, know more about team reflexivity than me and the definitions for it. But I think it is very focused on what teams do in response to their performance in real time. And I think what we've got is biased towards the sort of relationships that underpin some of that. I think the two are perfectly complementary. And I think team reflexivity has some good language as well that can help our teams get better. So I'd say you go for it. And it doesn't mean that it's good to read about other theories and how we drag our teams into using that just enough without them feeling like they're being theorized is quite a trick.
Yes.
How have you found it, can I ask?
So far, so good. I think one of the bigger challenges is that our ER has lost about 40% of its nurses. So just when they've stopped all other education, it's hard to say, well, buy into the thing that I want to study because it's more helpful.
Wow, super hard. And yet, interestingly, one of the things we found with our psychological safety is it was one of the things that was incredibly protective against more distress that you're talking about. And people were saying, well, we've got a lot of pressure and stress, and it's kind of like, well, yeah, but this is what's holding it together. It's not detracting from it. It's actually what's holding it together.
I think I've been wondering, what factors are protective against leaving, and towards supporting the staff to be able to do their best job, even in trying circumstances. So this is really informing how I think about that. Thank you.
Yeah. And we'll just add a little reference here. And the surname is Shah, S-H-A-H. And it's a return on investment framework for actually more for education, but including simulation. And it does include staff retention and turnover as one of the outcome measures that they used in the example they gave in the framework that they derived. So I think it's easy to underestimate some of those measures. And sometimes the institution collects some of that stuff, I don't know about you, but we have this yearly staff satisfaction survey and culture survey, and some of these are actually quite useful if you track them over time, and they can be one of a multiplicity of outcomes. Yeah.
Thank you.
Hi, this is Anne again. Sorry, I had another question. You talked a lot about culture and simulation, the culture compression. Do you do anything specifically for your sim educators when they're running sessions to make sure the culture that they're transmitting, again, in the way they facilitate and debrief matches? Because clearly we can't all be at all of our educators and faculty simulations. So how do we make sure that everyone is kind of transmitting that positive hitting curriculum, as you would say, or the right?
Yeah. Well, I think the first thing to realize is we probably have lapses all the time. So cut ourselves a little bit of slack, but I'll just explain what we've done in this the blog post with the equity, diversity and inclusion tool. Not that all of it is about equity, diversity and inclusion, but it's a good example. And I think we often race to try and fix things and think, oh, well, we'll design our sim to fix this problem. We'll deliver our sim so that we make sure we're all sending positive cultural vibes. And instead, we actually just have designed a reflection tool, which is designed to be a 5 to 10 minute reflection with the sim delivery team after the sim session, where we just ask ourselves, how did we go in terms of how we represent our patients and how we represented others who were involved in the sim? If we were playing the radiographer, did we, run that fine line between, appropriating skill sets that we don't have versus just making the sim happen because it's a feasible thing to do? Were there things that came up in the debrief that people might have thought of as microaggressions? How do we deal with them? And we're just literally trying to get into the habit of reflecting on what happened rather than necessarily trying to say we should be better and this is what we should do. And I think we often underestimate that step of, why don't we just be a bit more thoughtful about what we're already doing? And we've discovered in this particular area that our sim delivery team actually has some pretty limited understanding about equity, diversity, and inclusion. And even starting to talk about it, we don't have really many of the right words. Of course, we probably have started doing some more practical things, like we now do an acknowledgement of the traditional owners at the beginning of our simulation sessions, which we never used to do. And I think that's actually been a nice step. It's a small thing, but it's probably more important than we thought. So I think to answer your question, Anne, yes, of course, we should be describing some of the good practices in our faculty development, and we have a faculty development program like that as well. But I think also finding ways that our sim delivery team can explicitly reflect on those issues is probably a nice space to be in.
Victoria, building on this a little bit, and Maybelle Ku's point earlier about different sim cultures in different departments and divisions, it just makes me think that while Anne is referring to making sure the simulation team delivers a uniform experience across different departments, I think what Maybelle was pointing out was like a sim with the surgeons is different than a sim with the critical care team, is different with the acute care team, is different with psych. Should they all be that different? Or should the simulation program be working to make that culture similar in feel across different departments?
Wow, that's a really interesting question. I think we know that culture is hard to pin down, and I think that we know we get into cultural ruts in our interactions with some groups. My personal view is I don't think we need to be all the same. I think that said, some consistency about mutual respect is easy to agree upon, some consistency about trying to understand each other's roles. But at the same time, I think when you have different priorities and different things you work on, you will have different cultural norms. And I personally think that's fine. I think the opportunity for us in a debrief room, particularly if we have more than 2 teams together, is to make that overt, as it were, and help people understand why their conversation doesn't go well is because, as we said, they've got actually some competing realities. And so we've had a very limited and rather pedestrian approach to trying to sort this out, which is throwing competing facts at each other. And I've got one group I'm working with at the moment who want to have a seminar because they want to throw competing facts at each other. I said, let's just accept all your facts are right. All your facts are right. What are we going to do about it? And they kind of really get stuck then. But, and I said, no, all your facts are right. Why don't we sort of think about how we're going to have conversations that can reconcile that in the moment when we're making some decisions or when we find ourselves in conflict? Because I see a lot of us trying to tell juniors or colleagues about here's the words you use in your negotiation so you can win. But maybe, just maybe, the work we need to do is well before we need to have this winning conversation. So I know that's a conceptual level answer, but I think how I would summarize it is I think I would celebrate diversity of cultures within the institution, but be prepared to actually call that and name it so that it can be an enabler of better teamwork behaviors.
Thank you very much. That was very thoughtful because, I mean, exactly as Maybelle was pointing out earlier, then when you bring the critical care team with the acute care team and have them do a sim together, what does that look like? But I think acknowledging the differences and to me, more in the debriefing, likely that this is how we run sims with you guys, this is how we run sims with you guys. We're going to do a blended approach as we acknowledge everybody's different realities. I think that has a huge power.
I think one thing I would say, just at a practical level, is sometimes we do try and aim for too much in sims. So there's also like that's a lovely picture of the trauma sim with all these people in there, and that's such a triumph of getting people together for a massive multidisciplinary sim. But you know that every time we do that, that does mean that there's certain things we can't focus on. The only thing we can focus on in that kind of a sim is the interfaces between teams, because that's probably the only reasonable thing to expect people to take away from a sim like that. Whereas if we really want to work on airway management of the trauma case, and we just want to have the ED doctors and nurses and the anaesthetic registrars who come down to the call, then let's just do some much more focused stuff with that group. And maybe that will include some things that are more technical. So I think I've certainly started thinking much more targeted about having, here's our strategy, and it will include some big trauma sims. It will include a lot more team-based sims for the ED team. It'll include some where we have some deliberately designed interface type work with our visiting teams. Obviously, I say that from an ED point of view, but I think the same would go for wherever we were positioned. Maybelle, you've got some more to add to that?
I wanted to thank you for your response. Just to go on from some of the comments earlier during the large group about attrition of staff and the burnout that we're feeling in general from this pandemic, I wanted to hear about your thoughts on how to perpetuate civility and best regard when everyone's just had it.
Yeah, and look, I think I'm going to also as a Australian, we've had much less impact than you have, so I wouldn't want to sort of speak to your experience, but I think I know where you're coming from, which is when people get to a nadir, how can you sort of talk in a very Pollyanna way of like, be happy, have positive culture. I think you do have to meet teams where they are. And I've certainly, maybe not related to the pandemic, but worked with groups who were in a relatively bad place. And sometimes you have to go backwards before you can go forwards. And I think sometimes you might just have to give people a space to talk about where they're at before you can start talking about where they want to be and whether they want to improve. And I think we've seen some nice shift in focus for SIMS. Obviously, people worked for a lot of time on trying to shape the systems and processes, but I think now a lot of the work in, for instance, clinical debriefing has just been to allow people to describe and be validated for how they're feeling. So that said, I feel like one of the protective factors here is a spirit of trying to get better. And I don't think that is a overly optimistic way of describing it. I do think one of the retention things is if people are working on something and feeling like they're improving, even in small ways. And that has come out in some of our work on psychological safety. This was more related to SIM, but one of the protective factors against feeling that threat you do when you come to SIM and you think, oh my God, I'm going to be shown up and I look terrible. People would say that I feel scared to come to SIM, but it's so important because I feel scared to come to SIM, but you get to work with your team and you get to know the junior doctors better or whatever. And so I do think purpose is protective. And I know that's easy to say, but I think if done gently and appreciating where teams are at, then I think that's useful. I don't know. Is there anything that's occurring to you as useful?
I think it's taking that time, as you said, to sort of make sure that there's a note of appreciation without being Pollyanna about it. Very stimulating conversation. Thank you.
My pleasure.
I have quite a few more other folks here. And if anyone wants to contribute thoughts or have questions, please unmute and turn on your video and ask away. See a lot of folks that I've fortunately run across in some of the other sessions. So don't feel bad if I pick on you, but you made an effort to come to the Meet the Keynote session, and we'd be happy to have you engage directly with Victoria. If you have any questions, Karen or Ingrid, Mark, Dorcas, Melissa, Marissa, we're a small group, so very comfortable.
This is Karen Mathias from Children's Minnesota, and I just want to say how struck I was by your comment around really having this idea or these conversations about relational, the importance of these relational attributes when for so long we just thought if we teach the behaviors, they would come, and we almost downplayed the fact that we had different teams. And so I just really appreciate the conversation around that.
Oh, I'm so glad, Karen. And it's been a bit of a wake up for me as well. I grew up on CRM, both as a clinician, learning my first ever sim, like blew my mind. Wow, look at this cool CRM stuff. And then I think it became less of a framework and occasionally became a little bit of a cognitive prism, and we were just trying to norm people towards these behaviors. And then I think there was some research too. It wasn't just a realization. I think there's been some research that says, you know what, we can train people in closed loop communication, but they don't do it unless they have the underpinning values that mean they see its importance, or they feel like the people they're closing the loop with matter. And even that's relatively problematic, because every time someone gets airtime closing the loop, someone else doesn't get airtime saying something else. And I see in particular recaps and some of those things, doctors claim a lot of I speak to my own profession, doctors claim a lot of airtime in teams and team rooms, and you don't want that necessarily to be the dominant force, because every time you choose to communicate, there's someone else who can't take that space. So I've certainly come to even question some of the CRM behaviors, because all of them have got a flip side as well. So I think it's just part of the evolution, isn't it? What is a really useful framework has limitations. Surprise, surprise.
I'm also curious if you have done anything where people have had this good idea of getting a team together outside of work to have some kind of relational kumbaya meeting, and really people get very, we've tried this 5 years ago with a team that was just really struggling with patient safety, hierarchy, you name it, team behaviors. And we've been trying simulation for a number of years there. And I think there was the goal that we would get together outside of work and try to work on some things, but it really kind of backfired. So I'm just curious if you've had some things where you've learned from maybe things that haven't gone so well.
Oh, definitely. I think we underestimate the leap it takes to get a team into sim and actually learning from it. I think they often need to go through a process of understanding the modality and being able to get something out of it, and we underestimate what it takes to get there. Now, sometimes it's just those first awkward set of sims that we do with them where we kind of go, oh, well, they'll get better, they'll get it. But I think there probably can be things we do beforehand in order to do that. I think that taking people off site, one of the reasons that that becomes problematic is that people share work and they don't necessarily share their off-site interests. So some people go to a pub and then some people don't drink. Some people want to play virtual reality shooting games and other people doesn't turn them on. So I think carefully is the short answer. I do think it's not a bad idea to be able to extract people from the workplace to a place that is still a work designated environment, but isn't the buzzer ringing and I have to go off and attend to the airway. So I think there is room for providing a space for groups to come together and maybe being able to transform more into teams. And I like now to make that distinction. We've got a lot of groups in healthcare. We only have so many teams, I think, and trying to shift a group of people to becoming a team is multi-phased. So yes, have we had bad experiences? Absolutely. And usually it's when I've leapt too quickly into thinking this group can do a sim together and underestimated how much work we had to do before. Well, Pavan, we...
Excellent. Yeah, thank you very much. I think Marissa might have a question. I can't tell.
Oh, hi. Thanks. Yes, sorry, I don't know what's wrong with my video. You know, I've been definitely a big advocate of CRM, which we use in our trauma team program and our Sims for a long time. So I'm definitely someone who sees the value of it, but certainly recognize that anything has challenges or limitations, I should say. I think one of the biggest things that I keep thinking as I listen to this, as I'm thinking about our current day-to-day reality, is the pressures that everyone is under. Yes. And how to try to, you know, continue to ask. What did you just do? Joshua, keep it down low. Teamwork supports of folks when they are under so much stress, when those behaviors are simultaneously the most necessary, but also people have the least extra to bring to the table, as it were.
Yeah, and I think there's no panacea for that. Is the thing I would say over the last 12 months is that we have worked much more on the small moments and realized that they matter. And I think if I had to cancel my sim program tomorrow, as long as I could do the 5-minute team huddle in the morning where everyone said what their name was, and occasionally had an additional 5 minutes to do a talk through mental rehearsal of some challenge that might be in front of us. And in my case, it might be a patient arriving who's unwell. That would do. Because I do think this fosters a level of team familiarity that supports the psychological safety that we know supports the performance. So my only thought with that is to be trying to do those small moments, even if we know we can't pull people away for whole day lovely simulation activities. I think we have to recognize there will always be compromises. Yeah, you're right.
I like that the huddle and the, you know, maybe the 1-minute version of the 1-minute preceptor. When you know, we have a particularly rotating cast of characters with staff shortages. So I like that. Very nice.
Thank you.
So Dr. Brazel, a very heartfelt thank you for your time and for such great insights into all of these topics around collaboration and culture and translation. We very much appreciate it. Up next, we have oral themes. And so you can go and find which group of topics you want to go and get into a deeper dive with. And thank you very much for everyone's time. And thank you so much, Dr. Brazel.
Thank you so much, Pavan and team.